Let me talk a little bit more about the enteric infections, because infections can precipitate inflammatory bowel disease or they can mimic flares of inflammatory bowel disease. And several studies have looked at how common is this. And incidence of acute infection is anywhere from 8 to 20%. Campylobacter was the most common. That's the most common cause of infectious diarrhea anyway, or infectious colitis. But the real thing I want to emphasize is Clostridium difficile, because this is a really deadly combination, C. difficile and IBD. We really need to test for C. difficile infection in all of our patients with an IBD flare, as well as any patient with diarrhea, even in the community, even without antibiotics, because the epidemics of C. diff have been so marked since about the year 2000. So many studies have looked at the association of Clostridium difficile and inflammatory bowel disease. Patients with C. diff and IBD are hospitalized longer than patients with C. diff or IBD alone. They are younger, but remember that C. diff is much more common in the older patient population, so we really have to be aware of it here. And they have a higher mortality. They're more likely to die than compared to patients with either C. diff alone or IBD alone. So the risk factors in the IBD patients for C. difficile are having colonic disease, being on immunomodulator therapy, having more severe disease, and these patients, when they get C. diff, are more likely to go to colectomy, and remember, they may not have had any antibiotics whatsoever, so that's very important to have a very high index of suspicion for C. diff and order that test. So you want to test for C. diff in anybody in the hospital who's with a flare, or any outpatient who has a flare or an increase in diarrhea, or they're not responding to your therapy. And you probably want to continue immunosuppressive therapy, but maybe not increase it until the C. diff is controlled. And for patients with severe colitis who present initially, who may have both, it probably makes sense to do a combination of both therapies at the same time if you don't have your C. diff diagnosis right away.
And Chris, it's worth pointing out that the severity of colitis predicts or suggests which medication to use to treat C. diff. So if it's severe colitis, you probably want to use vancomycin rather than metronidazole. Given the data that you reviewed about the poor outcomes in IBD with C. diff, I actually consider IBD to be an independent risk factor for severe outcomes, and I have a very low threshold for using vancomycin in IBD patients.
And I agree. I think any IBD patient probably should start with vancomycin. I wouldn't even bother starting with metronidazole at that group.
This may be a good jump-off point for you to discuss your experience with the fecal enema therapy for C. diff.
Well, I've been using stool transplant, which we now call fecal microbiota transplant, for recurrent C. diff. I've done about 30 patients. A number of colleagues across the country have been using this as well. I have done 2 patients with inflammatory bowel disease. In both of them, we got rid of the C. diff, but the IBD symptoms didn't go away, probably because their disease was active. I have not been using it as primary therapy for either IBD or for severe episodes of C. diff colitis, but others have been, and it certainly is an area that we need to consider. But for standard of care, it's not there yet for the IBD patients.
It's important to emphasize that you can treat one and still have the other, so you just can't let your guard down that you think you've covered both bases.
Yes.
And that's often the challenge, isn't it? You find C. diff in an IBD patient. You can't tell which is driving the inflammation primarily, so you treat both. Sometimes get a little better, sometimes they don't, and then I think you're stuck.
And then the other thing is, how do you know if you treated the C. diff effectively? Right. So I think if you've given a full 14 days of vancomycin, I think you have to assume that you've done the maximal therapy. I wouldn't check for C. diff in the stools because it can be there as a carrier, or you can have organisms persisting that are no longer contributing to the care. So we've had that scenario come up several times, and at that point, after 10 to 14 days of high dose, 2 grams a day of vancomycin, we have to say, well, we think the C. diff is cured, let's focus now on the IBD therapy.
Yeah, and that's, I think, part of the reason why there's an increased risk of colectomy and even death, because how do you know? They're still symptomatic. Yeah. You assume, I think rightly so, that most patients would respond to a full course of vancomycin. But if it's still an infection and you give them steroids or stronger medications, then the C. diff can get worse. I think that's what makes this such a difficult problem. And
then colonoscopy may not be helpful because you may not see pseudomembranes.
Yeah. Very good point.
So what are the take-home points? That GI infections can mimic inflammatory bowel disease, or inflammatory bowel disease can look like an infection at the start. Infections can exacerbate inflammatory bowel disease, so we have to culture for enteric pathogens, and now we especially have to test for Clostridium difficile, because C. diff and IBD is a deadly combination for our patients.
I agree, Chris. In fact, I think we all would say that now, for any IBD flare, testing for C. difficile is the standard of care.
And this litigious population that exists, I think it's important to remember that you really will have your feet held to the fire if you don't obtain the C. diff data at the time that you introduce these other medications.